Doctors Unmasked with Dr. Brian Ceccarelli.
Hi, I'm Dr. Brian Ceccarelli from Doctors Unmasked, and today we're here to talk to anesthesiologist Dr. Maureen Leist. Tomorrow, this waiting room will be jammed with patients, me being one of them. I've taken time off work, I've prepared paperwork, I've made all kind of arrangements to have my procedure. Am I going to get canceled? I don't know. So what can I do to make sure I'm prepared to have that surgery? Today we're here to talk about anesthesia and some of the ways I could better prepare myself to have that procedure done. Stay tuned for this episode. I know that in anticipation of surgery, we frequently hear the term NPO. So what does NPO mean to me if I'm having surgery today? What does that term mean?
NPO basically refers to the guidelines for when you're allowed to eat and drink right up before surgery. Those guidelines are important because as patients get sedated and have anesthesia, relaxes every muscle in your body, including the muscle that keeps everything down in your stomach. If there's something in the stomach that wasn't meant to be there, that's going to come up, and then you run the risk of aspirating, and that's something that could cause pneumonia and be a pretty big complication. So the guidelines currently for anesthesia are for clear liquids for most surgical procedures up till 2 hours. Breast milk, human breast milk, is 4 hours. A very light meal or human milk is 6 hours minimum before surgery. Anything outside of that, a heavy meal, a high-fat meal, any kind of solid meal, you need a minimum of 8 hours between when you last ate that and your surgical procedure.
So when you say aspirate, can you explain aspiration? Is that literally when I throw up under anesthesia, and because I have a tube or something blocking my airway, that what I throw up actually goes into my lungs then? Is that what aspiration means?
That's exactly what it means. You know, aspirating.
And the risk of that is then I could get a serious infection and literally die from something going in my lungs that shouldn't be there.
It is, and the way I explain it to patients are even something as simple and little as water. If water is in your stomach, it comes up and gets into your lungs during an anesthetic. It's no different than drowning in a swimming pool. It's the same idea. That water is getting in your lungs, which is somewhere that it's not supposed to be, and that's where it can cause a pretty significant complication.
Okay. So when you tell me I can have clear liquids in the morning, so I can have a cup of coffee, I could have orange juice, I can have, what really constitutes clear liquids?
So clear liquids are going to be water. It's going to be Gatorade. It's basically going to be any liquid that you can see through. Chicken broth would account for that. Orange juice absolutely does not. You can't see through it. Orange juice is actually considered a solid with a minimum of 6 hours.
Wow.
Milk is a solid. Coffee is appropriate as long as there's no cream in it.
Gotcha.
So anything that basically makes it to where have that clear consistency is appropriate. For some surgical procedures, we actually have patients drink pre-surgical drinks that even not only have the clear liquid, have a little bit of glucose, even some amino acids with the intent of trying to continue bowel function prior to surgery. It's just very important that it stays with something that's clear.
Now, I know there's different types of anesthesia. There's general anesthetic. Somebody talked to me about maybe having a spinal, even having like a regional block or local anesthetic. Is there a way that you could briefly go over what those mean? What is a general anesthetic?
So general anesthesia really refers to the patient being asleep enough that they don't respond. They don't respond to verbal stimulus. They don't respond to pain. Most of the time, what's referred to as a general anesthetic also includes an endotracheal or a breathing tube. That has two roles. It allows us to give you the gases a lot of times that keep you asleep. It allows us to breathe for you when you're too sleepy and too sedated to do so. It also helps prevent anything from coming into your stomach during your surgical procedure, getting into your lungs. IV sedation, sometimes referred to MAC anesthesia, typically refers to someone who is asleep. A lot of times that patient won't remember much from during the surgical procedure. However, they're still awake enough that if they felt something painful or there was a loud noise that they would respond. Though it may not be a coherent response, there still would be a response. Then you have a spinal anesthetic. Without sedation, a spinal anesthetic, for instance, what we do for C-sections is basically going to anesthetize or numb you from usually around the rib cage down. It can and cannot include IV sedation on top of that. So just because you have a surgery done under spinal does not mean that you're going to be wide awake and aware. A lot of times you can be sedated to the point where you feel that you've had as much of a sleep during surgery as with a general anesthetic. And then the other extreme of that would be local, strictly local anesthesia. Typically is when the surgeon is going to numb up with local anesthesia, like what you have at the dentist, and you're completely awake. And for that, there are a lot of reasons to do that. Sometimes it's because the patient is too sick for an anesthetic. Sometimes they have other coexisting problems that make it to where they can't safely be anesthetized. Other times it's when the surgeon wants you to actually be able to move, whether it's move your eye during an eye surgery or move your finger so that they can see a tendon as it tracks in its face. Those would be reasons where you would do strictly local anesthesia.
So if I were having a local anesthetic, would I have to be NPO?
For strictly local anesthetics, no. For those, because there is no sedation, there really is no increased risk with having someone who's got something in their stomach. The risk there becomes as you start adding sedation to the mix.
Okay. And so I think we already talked about the risk to the patient, or my risk if I'm having the surgery if I don't follow that NPO. So it's very important, obviously, if I tell you that I stopped on the way here and I had a breakfast meal, and it's important that you would know that before you put me to sleep, correct?
It is. When we ask
So
you whether
don't
you've
lie
had
to your
anything,
doctor.
That's exactly right. It's exactly right, because anesthesia, kind of call it the great revealer, because I'm going to find out as an anesthesiologist one way or the other. One way I can prevent some pretty serious complications. The other, all we can do is manage them once they happen.
Okay. Now, if I choose to have a general anesthetic, and is it typically my choice to determine what kind of anesthesia? Is it your choice? Is it my physician who's doing my surgery's choice? Who determines what kind of anesthesia that I'm going to have?
It's a combination of a lot of things. Surgeon preference certainly plays a role in there. There's surgeons that with their experience want one type of anesthesia or another. For some surgical procedures, there's really no option but a general anesthetic or but a spinal. So sometimes it's dictated by the surgical procedure itself. And in others, it's more of a collaboration between the anesthesiologist, the surgeon, and the patient's wishes as well.
I see. So if I choose to have a general anesthetic, am I always going to have a tube in my throat?
Not always. General anesthesia by the anesthesia guidelines actually just refers to more a conscious level, whether you're responding to any kind of painful or surgical stimulation. Any kind of intra-abdominal procedure, or for most general anesthetics that does include a breathing tube, there are different kinds of that as well.
Okay. So if I have a tube inserted in my throat, am I going to wake up with it? Who determines, or how do you determine when that tube comes out? Because I have a big fear of waking up and not being able to get that tube out of my throat.
Yeah, that's a common fear. For the vast majority of patients, we do remove that breathing tube before you're going to have any memory of it. There are certain clinical conditions, morbid obesity, or patients who have breathing problems. There are certain clinical reasons why sometimes we hang on to that breathing tube a little bit longer. It's pretty rare that anyone has any memory of that, and typically if they do, there was a medical reason why we had to do that.
So are there any risk factors going into the surgery that you as an anesthesia person would know we're going to have a harder time getting the tube out of that person?
There are, not the least of which is if we have trouble putting that breathing tube in because of anatomy or because of something that you have as a medical condition. It's always harder to put it in the second time than it is the first. So we're going to make good and sure that you're ready to have that tube removed before we remove it, and that's just safety for the patient. There are some medical conditions that we wait a little bit longer, such as morbid obesity, someone who I feel will struggle to breathe more than others at the end of the surgery. We're just going to want to be confident that by the time we remove that tube, that patient is going to be successful without the tube, so that we're not in a situation where we're having to put it back in.
So once you decide you're taking the tube out, you're really feeling at that point that that patient's going to be okay breathing on their own.
Correct.
Okay. Now, what if I'm a smoker Is it harder for you to give me the anesthesia or put me to sleep? And is it harder to get the tube out if I'm a smoker?
Smoking absolutely does increase complications with the anesthesia. There's no question about it. The longer you smoked, the more you smoke per day, the more that's going to increase your risk. Anywhere from the spectrum of you have a higher chance of chronic bronchitis and coughing around surgery, to a higher chance of actually having upper respiratory infections that can be taken into a pneumonia, even to patients who have smoked for long enough and are now oxygen dependent and have COPD. That all is going to change the way that we manage their anesthetic. So smoking absolutely does increase the risk of a lot of things in anesthesia.
So if I were a heavy smoker, that may be a reason that you talk to me beforehand and say, maybe we should do a spinal on this person. Is that accurate or not really?
It absolutely is an option. Heavy smokers, even people with just severe asthma, that's a very reactive airway. The least we do with the airway, the least we have to put down there. Any option that avoids having to put anything in that airway is usually better for the patient.
Okay. So I'm on blood thinners. I take Coumadin for chronic blood clots in my leg, and I'm anticipating having a big surgery. When should I stop that blood thinner in anticipation of this surgery, and who's going to direct me in stopping that blood thinner typically?
Well, the reason we stop blood thinners around surgery is because, of course, you worry about bleeding from the surgical site, both during surgery and after. It really depends on what the medical condition that you required to be on that blood thinner is. Typically, that's something that the person prescribing it, whether it's your cardiologist, your primary care physician, your hematologist, whoever prescribes that, should be the one dictating when that blood thinner is both stopped and restarted. There are some surgical concerns with that. You know, after a spinal anesthetic, for instance, we usually say we want a minimum of a certain amount of time before you restart them. But it really is dependent on what your blood thinner is, what the condition that it's treating is, and what the person prescribing that medication is comfortable with.
So I shouldn't show up the morning of surgery saying I took my Coumadin today.
Some conditions, actually, you should be still taking it. There are some medical conditions in which the person prescribing is not going to allow you to stop it. And there are some surgeries where that would be appropriate and it would be acceptable. So it really, again, goes back to, depends on the reason that you're on it.
So if you were giving recommendations to me today, what I'm hearing is I should speak to the physician who has me on any blood thinner, let them know I'm having surgery, and they should make the determination when I should get off, if I should get off, and when I should restart the blood thinner. Is that a fair statement?
Yes, and
Okay.
optimally, that physician will have had a conversation with the surgeon as well, so that it can be a joint decision as far as what kind of surgical procedures can and cannot be done if blood thinners can't be stopped, and at what point it's safe for the patient to restart.
Okay. And I read somewhere where if I was on a blood thinner, I shouldn't have a spinal because I could get paralyzed. Is that true, or is that an accurate statement, or?
So blood thinners and spinals, there are set time periods where we know we're safe, and these based on what medication. There are all kinds of guidelines that are out there based on what specific medication, what blood thinner, a lot of times even just what dose of blood thinner that you're on, till we know that reasonably under those guidelines it's safe to do a spinal anesthetic. Peripheral nerve blocks or something similar. So what the anesthesiologist on your day of surgery is going to evaluate is how long you've been off that medication, whether you've exceeded the 48 hours, the 72 hours, whatever the safe time period is. If you're outside of that safe time period, then it should be safe in which to have a spinal or a regional anesthetic.
Okay. Now, I like to take multivitamins and supplements, and I take garlic pills and all kind of other things. Are there certain supplements or vitamins that absolutely need to be discontinued prior to surgery for the same reason they may increase bleeding, or are there certain ones that are absolutely you need to stop this?
In general, most herbal supplements should be stopped around surgery.
Okay.
There are many that do thin the blood, the G's, the ginkgos, and the garlic. There are also some that are stimulants, like your ephedrins. Those all are going to alter the type of anesthesia and how safely you get through your anesthesia. So those all, in general, with very few exceptions, should be stopped.
Okay. Now, I'm also a diabetic, and I just take pills for my diabetes. Should I take my pills that morning of surgery before I come in?
So that also depends on the type of medications and who prescribes them. There's a lot of different thoughts out there. In general, the oral hypoglycemics or your diabetes medications are safe to continue with the single exception of metformin. That's one that for most surgical procedures will want you to have withheld, usually at least 24 hours. As far as insulins and insulin sliding scales, typically, again, that's ideally managed by whoever manages your diabetes. There are some that will tell you to not take your dose at all, depending on what dose you're on. Others will tell you to decrease it by a certain percentage, decrease it by 50%. Others will tell you to actually check your sugar on the day of surgery and adjust. But again, that's really something that should be best managed by whoever manages the diabetes.
So when I come in the morning of surgery and I'm an insulin-dependent diabetic, will they normally do a fasting blood sugar when I get here and then anesthesia will adjust my insulin? Or I've never adjusted my own insulin on a sliding scale, so I'm not sure that I want to take that risk of either taking too much or too little. Is that something that would be done the morning of surgery?
Well, so hopefully you have an idea of what you're supposed to do with your insulin on the
Sure.
day of surgery from who prescribes it. On the day of surgery, we always will check blood sugar in the preoperative area, and we know that based on that blood sugar, we can put you on a spectrum of risk as far as complications. Blood sugars on fasting should be under 100. 100 to 125 is that pre-diabetic range. 125 and above certainly puts you in diabetes. Where we run into significantly increased complications with poor wound healing and infection really are those day of surgery blood sugars of greater than 200. So that's what you want to try and avoid.
So if I show up and you do a fasting sugar and it's 220, there's a good chance my case would get canceled if it were an elective procedure.
There's a chance that a blood
Okay.
sugar over 200 would be, and of course there would be other factors involved, such as how significant the surgery is, how urgent or emergent the case was to be. We certainly accept blood sugars higher for emergency situations than we would for something
Sure.
purely elective. But anything over 200, there's a lot of studies that show that you really are significantly increasing your risk of complications. And if it's purely elective, probably best to come back on a day when your sugars are more under control.
Okay. Now, if I take hypertensive medicine, for high blood pressure, should I take that the morning of surgery?
Well,
Or should I hold off on that?
That's really where the role of that preoperative nursing assessment comes into place. There are many classes of medications, such as lisinopril, and we call them the ACE inhibitors. A lot of studies show probably should be held. There are other medications, beta blockers being biggest among them, that it's really very important that you do take on the day of surgery. And so the hope is that having gone through that preoperative assessment, that your medication list has been reviewed so you have clear instructions on which medications to take.
So it may be a good idea that I even bring my medication with me that day just to show what I'm on in case I do need to take it after you evaluate me.
It's always great to bring your medications, that way there's no miscommunication with what you're taking. A lot of times though, by the time you arrive on the day of surgery, we're probably not going to have you take that pill right before surgery. A lot of times though, there are IV replacements that we will do, but it's never a bad idea to bring your medications on the day of surgery.
Okay. Now I know a lot of people are afraid of the nausea that they get after the surgery. Is there something that either I can do in preparation to reduce that likelihood of getting nauseated, or is there something that you as an anesthesiologist does to minimize my chance of becoming really sick after the surgery?
Well, I think the first thing is to make sure that you've listened to the guidelines as far as when it's safe to stop eating and drinking. A full stomach absolutely is going to be higher risk for nausea. The next most important thing really is to be honest with the anesthesiologist that talks with you. There are quite a few options that we have now, knowing someone has a higher risk of nausea, vomiting, than if we didn't know that. So by telling them, letting them know that right up front, there's a lot of things that we do differently to stay ahead of it, give you medications in the pre-op area so that hopefully that's not as much of an issue as it has been in the past for you.
So I had a friend who had anesthesia and they told me that they put a patch behind their ear which seemed to help them. Is that something that you recommend for people that have nausea?
There are a lot of medications that we have that we can do, scopolamine patch among one of them, but like all medications, there are side effects with anything that we're going to give you. So really whether one particular nausea medication or another is going to work is going to be a discussion between the anesthesiologist looking at the health factors, age, things like that.
Now, what if I've had a cardiac procedure? Say, for instance, that I had a stent placed 3 months ago, and I have been scheduled for an elective total knee replacement. Is that something I could safely undergo at 3 months after a stent? Is there guidelines that determine how long I have to wait after having a stent?
There definitely are guidelines with cardiac stents, really based on what type of stent you have. The most common type of stent that we typically are seeing these days is called a drug-eluting stent. It's a type of stent where we don't want to stop blood thinners, usually within 6, if not a minimum of 12 months of that stent being placed. If you stop the blood thinner too early, you run the risk of the stent becoming included, either during surgery or in the day or two after surgery. So that's something that we would discuss with your cardiologist. There are very few instances in which we would take you for any kind of elective procedure outside of 6 months prior to, or from having your stent placed.
So I have a stent placed, I should pretty much count on waiting 6 months or longer to have an elective procedure.
Again, it depends on what type of stent you have, certainly. The safest, without any doubt, is going to be waiting outside 12 months.
Okay.
6 to 12 months is going to be a gray area. That's going to be a discussion based on the risk of waiting for surgery
Sure.
versus what the cardiologist thinks and how safe they think it is to get you through. But at a minimum, usually 6 months is the earliest that they'll want you to stop any type of blood thinners with some of these drug-eluting stents in place.
Okay. And at one point during our conversation, you talked about morbid obesity. What role does weight have in either putting somebody under anesthesia or the difficulty in waking them up if they've had a general anesthetic?
Well, morbid obesity is certainly something that we are seeing more and more of and isn't going away. It does change anesthetic in many ways. There are some medications we have to give more of. There are some medications we actually give less of. The risks of anesthesia are significantly higher the heavier you become. The risks start with the preoperative area, having risk of the comorbidities, right? You've got high blood pressure, reflux, asthma. As you go back through surgery, the biggest thing that happens in the beginning part of the anesthetic is when we place a breathing tube. People who are morbidly obese, that becomes more and more challenging. On top of that, the more weight you have putting on the chest, the quicker your oxygen level is going to drop during both going to sleep and actually waking up as well. So it does change that, alters the medications that we give. And in the recovery area, the biggest thing we tend to see, people who are morbidly obese frequently have sleep apnea, which is going to make it longer to wake up. They do increase their risk of respiratory or breathing issues after anesthesia, certainly especially with narcotics. One of the biggest things that we try and do in anesthesia is to try and minimize narcotics, minimize gases, minimize the anesthesia we give you to the extent that it's possible. Things like local anesthetic, regional anesthetics can help, but you have to understand that morbidly obese patients, even the placement of these regional anesthetics is challenging. Even the placement of IVs is going to be more challenging for the nurses in the preoperative area.
Okay. Now I know that on the morning of surgery, there's always a chance that my case may get canceled based on whether I just got over an upper respiratory tract infection or I complain of some breathing issues. When you evaluate a patient, what are some of the most common causes that would cause a case to get canceled the morning of the surgery?
The most common cause really is failure for a chronic medical problem to be optimized. So your blood sugar is not controlled. You get here on the day of surgery and your blood pressure is not controlled. If you have issues such as with your heart that you've never addressed, say you tell your anesthesiologist that you admit to having chest pain for the last couple of months and no one has worked that up, that's something that certainly we would cancel before we can safely put you through an anesthetic. Illnesses, upper respiratory infections, that can be common, especially in the winter months. Honestly, we kind of base that on a judgment call when the patient gets here. We're going to see how long it's been going on. Are symptoms resolving? Do you have fevers? Do you have a cough that's productive? Sore throat? All of those would increase the chance that we're going to tell you that it's probably safer to wait a couple of weeks before you come back for something purely elective. The other issue we run into is if someone didn't go through that preoperative testing, we can't do your lab work until the day of surgery, and we find a potassium or we find a lab value that's abnormal and would prevent us from doing anesthesia.
Okay. So with the boom in the opioid crisis, I know that you see patients that probably are using recreational drugs. Why is it important that I tell you that I use what I would consider a recreational drug?
Yeah, that's something that we see a lot, and I think there's a lot of taboo along with a lot of these recreational drugs. People are in the habit of keeping it secret from family, from friends, from work. It's important you not keep that secret from someone who's trying to get you through an anesthetic or through surgery. Everything from recreational marijuana use, we know there is a pretty significant increase in how much it may take to keep you asleep. If you don't tell me about that ahead of time, you run the risk of waking up in the middle of surgery. Knowing that ahead of time, we're going to manage that anesthetic differently. There are other recreational drugs such as cocaine, amphetamines. Those, if they're in your system on the day of surgery, can significantly increase your complications. And the complications associated with that are pretty severe. We're talking heart attack, arrhythmias with your heart, even stroke. So those kind of medications, it actually may change whether or not we can do your anesthetic. We'll check blood work, we'll check urine and check it on the day of surgery. If it's there, we're going to cancel it whether you tell us or not. The worst case scenario you would have is to not tell that anesthesiologist taking care of you, and then things have to get figured out in the middle of the surgery, which is just going to put you at increased risk.
So the bottom line is, if I'm doing some recreational drugs, I got to be honest with you because it may save my life under anesthesia.
Yeah, there's no judgment in any way. It's just telling me what I need to do to get you safest through that anesthetic. Absolutely.
Okay. And then the last question I have for you, Dr. Leist, is there anything as far as recommendations you could make to somebody who's going to have a fairly big procedure in, say, a month or two? As an anesthesiologist, can you sit here today and say, this is what you can do to liken the chance that you're going to get through the surgery fine and have less complications?
There's a lot of things, from stopping smoking as soon as you find out that you're having a surgical procedure. You know, a lot of things we talk about, the breathing issues with smoking, but what a lot of people don't realize is that smoking actually makes it harder to heal from your surgery. The earlier you stop, the more your body's going to have a chance to recover from that. The other thing is just to work with your primary care physician, work with whoever it is that manages your chronic medical conditions, and make sure they've been optimized. Make sure your blood pressures are controlled as well as they can. Make sure your blood pressure medication has been taken as it's supposed to be taken and that it's under control. The things that patients can do at home, and make sure you check your own blood sugars. Make sure you get a blood pressure cuff. Check your blood pressures while you're at home. It's going to decrease the chance of you getting here on the day of surgery, having your blood pressure so high we can't get you through an anesthetic.
Okay. Well, listen, I think that you answered all of my questions. I think that everything you talked about certainly makes sense to me. So I'm ready to have the surgery and the anesthesia that you recommend.
Okay.
Thank you so much.
Thanks.
I hope you enjoyed this segment on anesthesia. Why is this so important? Did you know that roughly 8% of all surgical cases will get canceled the morning of the surgery? Not only is it inconvenient to you, who's taken time off work, arranged a driver, prepped yourself for the surgery, but it's also costly to the hospital. It costs hospitals millions of dollars every year from surgical cancellations. So I think it would be prudent if you follow the guidelines that Dr. Leist talked about in our video, and I hope you found this segment enjoyable and informative. We'll see you back here on Doctors Unmasked.